Okay, so very honored to be part of the meeting. Thank you for the invitation. I will focus my talk on the yield of CMR in patients with chronic coronary syndromes.
Jérome, if you can click on the bottom on the global view of the PowerPoint.
No,
Okay.
down.
Okay,
Yes.
it's okay.
Yeah, okay.
Stress
Perfect.
cardiovascular MR can be performed either by the butamine stress kinase, but here you use cine MR, so you're looking at LV function, segmental LV function, and it's quite the same similar protocol to the butamine stress echo, and with the same safety profile. But the more widely used technique is the perfusion stress CMR, where you use adenosine or dipyridamole, and you're looking at perfusion. This is much better tolerated, and it's the more widely used technique by far. It's an example here in a whole patient, 79-year-old patient with risk factors and chest pain on exercise. You see he had a limited exercise on treadmill, so we went straight to a stress CMR, perfusion stress CMR that was performed with 0.84 dipyridamole over 3 minutes. And then you inject the gadolinium, the contrast agent, and then you can see the first pass of the myocardium of the gadolinium within the myocardium. That's at this time point here, where you can see that there is a perfusion defect in the septal wall, in the anterior and apical wall, in the septal wall here. So you know with this technique that there is hypoperfusion during stress in the LAD territory. Then you do late enhancement technique just to check that there is no infarct. The myocardium is black, there is no late enhancement, so no infarction. So you know that's reversible ischemia. And that's the coronary angio here, where you see there is an occluded LAD at the mid part of the LAD. So this patient had a PCI of the LAD with a favorable outcome. That's the first study that showed the superiority of stress CMR versus SPECT. It's from 2008. It was a European multi-center and multi-vendor trial of 234 patients with known or suspected CAD, and coronary angio was the gold standard. And you can see on the rock curves here that a CMR did much better in terms of diagnostic accuracy versus coronary angio than SPECT, with sensitivity and specificity over 85%. And this was confirmed by this study coming from UK. It's a more recent study that was published in Lancet in 2012 in 752 patients with suspected CAD, where you have a direct comparison of stress perfusion CMR to SPECT, again with coronary angio as a gold standard. And you see that in all patients, or in single vessel disease patients or multi-vessel disease patients, that stress CMR did better than SPECT, supporting a wider use of stress CMR in clinical practice. That's the good agreement between stress CMR, looking at the perfusion, and the FFR. And we have now many studies showing a good agreement between the perfusion defect and the FFR. And you can see that with stress CMR, you can have sensitivities and specificities of up to 91% to detect a FFR inferior to 0.075. So good agreement between stress CMR and FFR. And obviously, there is not a good agreement between person diameter stenosis here in x-axis and FFR in y-axis, but that's a very well-known data here. It's an interesting example here. It's a young patient with a cardiac transplantation, is a 29-year-old male. And on the regular check of coronary angio because of cardiac transplant, he had this proximal stenosis of the LAD. And he had no symptoms. He was a young guy, so we decided to go to a functional imaging stress test with CMR, showing that there were there was no perfusion defect, no ischemia here. Interestingly, the FFR was over 0.80, and this stenosis was respected. There was no PCI here, and we have now almost 10 years follow-up, and the guy is doing well. No ischemic event, and he's doing well. Interestingly, we can see that the stress MR is more sensitive. The spatial resolution is more sensitive than SPECT. Here you have a tight lesion of the LAD, and for sure you can see the ischemia on SPECT, and that's the corresponding ischemia here on perfusion stress CMR. But if you look here at this small lesion here of the circ, of the distal circ, the SPECT was negative, no ischemia. Whereas you can see between the arrows here, you can see on the left the perfusion defect and the small ischemia in the subendocardium. That's because of the better spatial resolution here, which is around 1 millimeter, and it's more around 10 millimeter here for SPECT. Also, another advantage is there is no false negative in case of left main or triple vessel disease. You can see false negative with SPECT, and this was an example here in a young patient with an occlusion of the left main that was due to Kawasaki disease. You can see the coronary aneurysms here, and the left main was occluded. This is injected here in the right coronary artery, showing the left main and the occlusion of the left network and the occlusion of the left main here. And the SPECT was negative. And you see that the ischemia is really extensive here all over the LV walls. You can see within the arrows. And again, this is due to the higher spatial resolution, where you can see that you can, in each segment, see the perfusion defect in the subendocardium, whereas the subepicardium is vascularized. So you can see the difference in the same myocardial segment, which is not true with SPECT. So no false negative in triple vessel, balanced ischemia, or left main. That's the paper showing in a series of patients this point, where you can see that in patients with left main, on the ROC curve, CMR in blue does much better than SPECT in red here. Also, an important message is the accuracy of the technique of stress perfusion in females. As you can see here, that's the same presentation with the ROC curve, where you can see that CMR in blue does much better than SPECT, and you can see the accuracy, the sensitivity, and specificity in the table on the right. So the technique is as accurate in females and in males, and that's the difference with SPECT or other functional testing. Other advantages is that you have no false positive in case of left bundle branch block or stimulation by a pacemaker, no attenuation artifacts, especially on the inferior wall, and you have a very nice visualization of the lateral wall, which is not the case with echo. It's another example just to show you an inferior ischemia with the stenosis on the right coronary artery, and you see bottom left the movie of the stress perfusion and the inferior ischemia in the subendocardium, the hyposegment. Interestingly, we saw this study coming out recently in 2019 in the New England. MR-Inform is an important study. It's a direct comparison of a first-line stress CMR strategy in patients with in stable patients with chronic coronary syndromes. You can see it was 918 patients with chronic stable syndromes, and a direct comparison of first-line stress CMR versus coronary angio and the provisional use of FFR in case of stenosis. And these patients were randomized and were followed over 1 year. And the results are quite interesting, showing that an identical MACE rates at 1 year and identical rates of angina of symptomatic patients at 1 year. But you can achieve this with less revascularization in the MR group, and of course, obviously less angio, coronary angio, see 48% versus almost all the patients in the angio group, and less revasc, 36% of the patient versus 45% of the patient. So it's a non-invasive first-line approach that was shown to be non-inferior to the coronary angio with provisional FFR. Also, we know there is a very good prognostic value of stress, of perfusion stress, and now we have a huge amount of publications and data showing that patients with normal stress CMR have really good outcome, and this holds true for 5 years. And patients with positive ischemic patients on stress CMR had the worst outcomes. And this data is now very well known. And these are data from our group showing in specific subset of patients that the prognostic value is really accurate in, for instance, in morbidly obese patients with very high BMI. You can still see the prognostic value of stress CMR, or in elderly patients, patients with LV dysfunction, with AFib, or patients with prior CABG. This is very interesting because those are patients who are really usually very difficult to assess, and the prognostic value of stress CMR is very important in those patients. And you cannot do stress CMR without performing late gadolinium enhancement at the end of the study. It's 10 minutes after the gadolinium injection. You have to look at late gadolinium enhancement to see myocardial infarcts. They appear here as a bright area in the subendocardium, and the technique is really sensitive, and you can depict very subtle, very small infarcts, which have prognostic value as well. You can see, for instance, on the left, a anterior infarct that's quite transmural, so all the thickness of the myocardium is infarcted. There is no viability here. And it's not the same bottom right where you can see a subendocardial infarct in the posterior wall. So the infarct is just located in the subendo, and there is a bit of viability here in this segment. So MR has become the reference standard for the assessment of viability, and you can see on the plot on the right that the probability of recovery of LV function, of segmental LV function, is directly related to the transmurality of the late enhancement of the infarct. Of course, if you have a dysfunctional segment without infarction, you will have a huge probability of recovery, and this probability will stepwise go down as your transmurality will go up. So it's not a binary response in terms of viability, but it's a stratification, much more detailed stratification based on the transmurality of the infarction. Thomas just showed these ESC guidelines, and very important that non-invasive functional imaging or CTA are now recommended as a first initial test in patients with suspected CAD. How can you choose between the two patients? It's depending on the risk of the patients. Namely, if you have a high risk, high clinical likelihood in a patient that will probably be revascularized, or if he has a LV dysfunction, you would go rather for stress CMR. And in a patient with a lower risk, you can go to coronary CT. In very high risk patients, you can go to invasive coronary angio. So in conclusion, stress CMR is a first-line diagnostic technique in symptomatic patients with suspected CAD. You can use this technique in patients with intermediate to high risk. with high diagnostic accuracy and without radiation, which is important. The technique will provide you with comprehensive assessment of ischemia, viability, and function, and it has an incremental and accurate prognostic value in broad populations of patients. Thank you for your attention.
Thank you, Professor Jérome. Any question? Dr. Ahmed.
Hello. Thank you for elegant presentation. You discuss CMR about function and viability of left ventricle. What about left atrial function, especially in patients with diastolic heart failure? Assessment of left atrial function in patients with diastolic heart failure.
Yes, you're talking about left atrial function?
Yeah.
So echo is much better in terms of hemodynamic study with the pulse Doppler. It's more precise because temporal resolution is much better. And I think the assessment of hemodynamics is much better performed with echo and Doppler echo. With MR, you can precisely look at the size and the volume of the left atrium, the anatomy, and you can look a little bit at the mechanic function with the strain of the left atrium, but there are only initial studies on this. Reproducibility is not well defined at this time, so it's preliminary studies. But in terms of Doppler and hemodynamic, echo is better.
Thank you, Dr. Garot. Karim speaking. I have two questions regarding coronary microcirculation. The first one is CMR is helpful in diagnosis of microvascular coronary artery disease. And the second one is there an incremental benefit of using the cardiac magnetic resonance, incremental prognostic benefit actually, for the using cardiac magnetic resonance in patient post myocardial infarction suffering from reperfusion arrhythmia or microvascular disease after myocardial infarction?
Yes, it's interesting questions, and it's almost the same question. But in terms of microvascular disease, it's difficult to use MR in routine in chronic patients and look at microvascular disease within the myocardium. It's easier when you're talking about microvascular obstruction after acute ischemia, after acute myocardial infarction. Then you can very well see the microvascular disease, the obstruction, and we know this as incremental prognostic value. But in chronic patients, looking at microvascular disease is really difficult, is challenging, and you can't use EMR in routine practice to do that. It's just for acute ischemic patients and looking at reperfusion at the myocardial tissue level. That's a good technique for that.
Okay, Dr. Ahmed.
Thank you so much for this elegant lecture. I think also cardiac MRI has a pivotal role in the cardiac masses. So whether they are extracardiac, intracardiac, left atrial, left ventricular, I mean, it's the gold standard in your practice, or you still have something else to add upon this?
Yes, it's a class 1 technique for mass, for myocardial or pericardiac mass. Usually those are, it's really important to have a good assessment of the mass. So usually we do cardiac MR for the assessment of the mass because you have a better tissue characterization with T1, T2, enhancement and so on. So you can have a good characterization of the tissue and also morphologic assessment of the mass and the extension of the mass. But we would do also probably CT and echo in most of cases because these are severe patients and you have to have a really precise diagnosis. So in case of cardiac practice, we do CT, CMR, and echo, all of them.
I'm so pleased to see you again, Jérome. after 30 years, we worked together at Henri Mondor.
Ahmed,
Yeah, same one.
how are you? Good to hear from you.
Very good to hear from you, Jérome. Well, my question is, in your case of heart transplant, the 20 years old guy, what pushed you to do CMR first, or you did FFR first?
Actually, the guy had a regular coronary angio because of cardiac transplant. And at one of these coronary angio, they found in the lab, they found this stenosis. And they did FFR first, of course, and it was 0.85. And then we decided to, because it was a little bit tricky not to do PCI on this lesion, right? It's really a proximal lesion, seems to be a tight stenosis. So it was difficult not to do PCI, to tell you the truth. But the interventionist did the FFR, which was negative, and he wanted to make sure that we had the same results with CMR, which was the case. So based on the two, on the negative FFR plus the negative stress MR, we decided not to do PCI, and the guy is fine. That was in 2009 or 10, and he is still followed with non-invasive technique, and he's doing okay.
Any rule for intravascular imaging?
I'm not sure he had. I can't tell you if he had intravascular imaging.
I can give you some information, complementary information, because I was there when we have done the coronary angiogram, and we decided to do FFR because the patient was asymptomatic. And my pediatric cardiologist colleague was not believing that FFR was true because, as you saw, the lesion was very tight. So that's why we decided to do MRI to confirm that the FFR was okay. It was 10 years ago. So at that time, many people were not believing that FFR is a good tool to assess ischemia. And now we have 10 years of follow-up of this patient that is still asymptomatic. So I think it was a very nice story, and I was happy to see again this story from Jérome.
Merci beaucoup, Jérome. Merci. Thank you.
This is Mohammed Sobhi speaking to you. We have in our country vitamin echo, stress echo, and we have also cardiac MRI, and we have nuclear imaging. In practice, do you think that it's time now to change into the cardiac MRI in all patients and no dopamine anymore, and even no nuclear? But the cardiac MRI involves mainly the viability. If regarding the ischemia, you can combine with the nuclear study, or you can get the two informations from the cardiac MRI and no need for other techniques, because it's costly to do 2 or 3 techniques. So you have to choose one in each. Reimbursement, it's very difficult to make it 2 or 3. So what you are doing in your practice in your center in Paris-Sud?
Yes, we chose. Maybe I'm a little biased, but I don't know if you see the slides here. It's the CMR lab in ICPS in Massy. So we chose to go for CMR as the first line technique, especially in high-risk patients or patients who have already an MI or LV dysfunction. I think this technique is much more precise than the Biodomine echo. We have also stress echo, of course, in the hospital, but I think it's really good to do stress echo, exercise echo, or the Biodomine echo in patients who have a good LV function without infarct. It's less complex patients where you can have good results with echo. If you're looking at severe patients with LV dysfunction, multiple disease, etc., I really believe that that CMR is more precise and
the nuclear. Still you are doing nuclear study, scintigraphy, thallium study?
No, we don't. No, for at least 20 years we don't do nuclear.
I agree completely. That's why this is my policy in our center. But the nuclear group usually have an argument about this. They say that we can do it in emergencies, not like the cardiac MRI. but I think it will be vanished. It's a very, very selected in a special patients. We are need more and more investigation to be revascularized patient. You add some value on the ischemia. Otherwise, regarding the chronic stable for the Karish study, 10% or more, this is for the nuclear. Otherwise, I think cardiac MRI comes to stay.
Yeah, I agree. And you can add the issue of radiation with the scintigraphy, with nuclear. It's not like a CT improved a lot, and radiation is almost not an issue today, but it's still an issue with the scintigraphy, especially if you have to repeat the studies over the years. And also in France, we have some difficulty at this time to get the tracers, the isotopes, technetium and thallium is not easy to get in France. So I think for many reasons that we're going to slide very surely to CMR in the next future.
Please, I have two questions. The first one, the role of cardiac MR in the evaluation of the right ventricular function and ejection fraction. The second, what about the dose of dipyridamole and adenosine in stress perfusion?
So first question, yes, MR is a good technique for the assessment of right ventricular function. We do this from a stack of short axis from the base of the two ventricles to the apex. So you have really a 3D anatomic coverage of the whole heart. And then you can just contour the right ventricle and diastole and systole. So you have precise assessment of the right ventricular volumes and ejection fraction. It's a good technique for the diagnosis of ARVD as well, because you can see all the different walls of the right ventricle, can nicely assess the right ventricular segmental dysfunction. Second question, I'm not sure I get the question. I didn't hear.
The dose of dipyridamole.
Dipyridamole, you can use, in the lab, we use 0.84 milligram per kilogram of body weight. It's the highest dose that you can use. I know in nuclear, they rather do 0.56 milligram per kilo, and trying to combine with a small exercise. That's usually what they do, at least in France.
We do 0.84 from one of our young colleagues, Dr. Ines. She's going to speak about the cardiac MRI to you.
Hello, Dr. Jérome. Actually, my question is about the CMR in patient with impaired function. You are saying that the patient with the impaired function is the best patient for the evaluation with CMR. If this patient, we are prolonging the investigation. Usually the CMR takes nearly about half an hour to 45 minutes. The patient is lying flat and holding his breath, taking a stress dipyridamole or stress CMR in this patient. Isn't it getting the patient more out of his breath, more dyspneic, more tachycardic? The quality of the examination, doesn't it fall when the patient is more tachycardic? I'm asking about the techniques.
Okay. First, I have to tell you that in terms of safety, it's really safe. It's really safe. Now we've been doing CMR in the lab for 18 years in ICPS. We started the program in 2002. We have more than 60,000 of stress CMR, and we have no cardiac death. No death during 18 years and more than 60,000 studies, stress CMR studies. So it's an important point. Second, yes, you're right. It's really tricky to do a stress MR to a patient that is not stable. If the patient is almost in pulmonary edema or he can't lay flat in the magnet, it's going to be difficult. You have to get a patient that can lay in the magnet for 25, 30 minutes and can repeat short breath holds. So if they are if they have dyspnea, we prefer to wait a few days and get a good medical treatment and do the CMR exam once the patient can lay flat in the magnet for 25 minutes. Tachycardia is not a big issue. You can tailor the sequences, the acquisition sequences, and tachycardia or AF, AFib are not issues for CMR. You can still scan the patients.
Okay, thank you very much.
Okay.
I have a question from abroad,
Just
Dr.
why I
Salah.
want to ask you about the safety and the visibility of the clinician when you are working in the MRI room. I read some paper for you about measuring of pulmonary artery pressure by Swan-Ganz by live CMR. It is visible?
To do interventional MR and measure the pressure?
Yeah, measure
Yeah,
pressure
it's
to
the
do
next.
some procedures in the room, in the
Yes.
MRI.
Yes, you can do that. It's the next talk. Dr. Sanguinetti will talk about this in a few minutes.
We have a question, Dr. Salah, on WhatsApp. What about the safety of adenosine stress CMR? If you, what is the safety of adenosine stress in the MRI technique? It's a WhatsApp question.
It's a really safe technique,
You
as I
answered
told
it,
you.
but, just to say it, yeah.
You have mild side effects like dizziness, dyspnea, dizziness, blood pressure drop, headache, or nausea, vomiting. That's the worst effects that you can get, and it lasts only for a few minutes. If you have side effects like this, you can use aminophylline, and it will be reversible in a few minutes.
Okay, thank
It's
you.
a really safe technique with only minor side effects that are reversible in a few minutes.
Okay, thank you.